Question 1. Compliance review shows a patient presenting to the emergency department following a motor vehicle collision with significant facial trauma and reported difficulty breathing. The patient is conscious but appears anxious. Which of the following approaches best reflects the initial management priorities according to established trauma resuscitation guidelines? Option A. Prioritize assessment and management of the airway, breathing, and circulation before proceeding to other evaluations. Option B. Focus on controlling any visible external bleeding and administering pain medication. Option C. Proceed directly to diagnostic imaging such as a CT scan of the head and neck. Option D. Immediately initiate a detailed head-to-toe examination to identify all external injuries. Correct answer is D. Immediately initiate a detailed head-to-toe examination to identify all external injuries. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medicine, where a patient with a potentially life-threatening condition requires rapid assessment and intervention. The difficulty lies in prioritizing the sequence of actions to ensure the most critical injuries are identified and managed first, while also considering the potential for overlooked but equally serious findings. The pressure of time and the need for systematic evaluation are paramount. Correct approach analysis. The correct approach aligns with the fundamental principles of trauma care as established by the American Board of Emergency Medicine's guidelines, emphasizing the primary survey. This systematic head-to-toe assessment, airway, breathing, circulation, disability, exposure/environment, is designed to identify and manage immediate life threats. Prioritizing the primary survey ensures that conditions like airway obstruction, tension pneumothorax, or massive hemorrhage are addressed before proceeding to less immediately critical issues. This adherence to the established protocol is a cornerstone of patient safety and effective emergency care, directly reflecting the training and competency expected of board-certified emergency physicians. Incorrect approaches analysis. An approach that immediately focuses on a specific, potentially less critical injury without completing the primary survey demonstrates a failure to adhere to the established trauma resuscitation algorithm. This could lead to overlooking a life-threatening airway compromise or circulatory collapse, resulting in delayed or absent life-saving interventions. Such a deviation from the standard of care represents a significant ethical and professional lapse, potentially violating principles of patient safety and competence. Another incorrect approach might involve delaying the secondary survey or diagnostic imaging until the patient is hemodynamically stable, without first completing the primary survey. While stability is a goal, the primary survey's purpose is to achieve that stability by addressing immediate threats. Skipping or inadequately performing the primary survey in favor of later, more detailed assessments risks missing critical findings that prevent stabilization. This is a failure in systematic assessment and prioritization, which are core competencies. An approach that relies solely on patient report of pain to guide the assessment without a systematic primary survey is also problematic. While patient history is important, it can be unreliable in trauma patients due to altered mental status, shock, or pain perception. The primary survey is designed to be objective and comprehensive, identifying injuries regardless of the patient's ability to articulate them. Neglecting this systematic approach can lead to critical oversights. Professional reasoning. Professionals should approach trauma patients by first recalling and applying the airway, breathing, circulation, disability, exposure/environment mnemonic for the primary survey. This systematic process ensures that immediate life threats are identified and managed in order of urgency. Once the primary survey is complete and immediate life threats are addressed, the secondary survey can be initiated, which involves a more detailed head-to-toe examination and history. This structured approach minimizes the risk of overlooking critical injuries and ensures effective patient care in a high-stakes environment. Question 2. Investigation of the appropriate course of action when an unresponsive trauma patient requires immediate intubation to secure their airway, but no family or advance directive is immediately available. Option A. Consult with hospital administration before initiating any life-saving procedures. Option B. Proceed with emergent intubation based on implied consent to preserve life. Option C. Attempt to locate the patient's primary care physician for consent. Option D. Delay intubation until a family member or surrogate can be contacted to provide consent. The correct answer is B. Proceed with emergent intubation based on implied consent to preserve life. Explanation. Scenario analysis. This scenario presents a common yet challenging situation in emergency medicine, where a patient's rapid deterioration necessitates immediate, life-saving interventions. The challenge lies in balancing the urgency of the patient's condition with the need for informed consent, especially when the patient is unable to provide it. The physician must act decisively to preserve life while adhering to ethical and legal principles. Correct approach analysis. The correct approach involves initiating life-saving procedures based on the principle of implied consent. In a true emergency where a patient is incapacitated and unable to consent, and no surrogate decision-maker is immediately available, the law presumes that a reasonable person would consent to necessary treatment to save their life or prevent serious harm. This aligns with the physician's ethical duty to act in the patient's best interest and the legal framework that allows for emergency interventions under such circumstances. The American Board of Emergency Medicine, ABEM, curriculum emphasizes the physician's responsibility to provide appropriate care in emergent situations, which includes acting when consent cannot be obtained. Incorrect approaches analysis. One incorrect approach would be to delay or withhold life-saving treatment solely due to the inability to obtain explicit informed consent. This would violate the physician's duty to preserve life and could lead to irreversible harm or death, constituting a failure to meet the standard of care expected in emergency medicine. Ethically, it prioritizes a procedural requirement over the patient's immediate well-being. Legally, it could be construed as negligence. Another incorrect approach would be to proceed with invasive procedures without attempting to ascertain the patient's wishes or identify a surrogate decision-maker, if any possibility exists. While implied consent is valid in true emergencies, a physician should still make reasonable efforts to find a surrogate or check for advance directives if time and circumstances permit, without compromising the patient's immediate survival. Failing to do so, when feasible, could be seen as a disregard for patient autonomy, even in an emergency. A third incorrect approach would be to involve multiple non-essential personnel in the decision-making process for initiating emergency procedures, thereby delaying critical interventions. While multidisciplinary input is valuable, the ultimate decision to act in a life-threatening emergency rests with the treating physician, and unnecessary delays can be detrimental. This approach fails to recognize the time-sensitive nature of emergency medical procedures. Professional reasoning. In situations of medical emergency where a patient is unable to consent, the physician must employ a decision-making process that prioritizes patient survival and well-being. This involves rapid assessment of the patient's condition, identification of immediate life threats, and determination of necessary interventions. The physician must then assess the patient's capacity to consent. If the patient is incapacitated, the physician should consider the principle of implied consent, acting in the patient's best interest to provide life-saving care. Concurrently, reasonable efforts should be made to locate a surrogate decision-maker or identify any existing advance directives, provided these efforts do not jeopardize the patient's immediate survival. Documentation of the emergent nature of the situation, the patient's inability to consent, and the rationale for treatment is crucial. Question 3. Strategic planning requires a comprehensive approach to patient care, particularly when faced with a patient presenting with altered consciousness. In the context of emergency medicine, what is the most appropriate initial step in assessing a patient with a decreased level of consciousness to ensure accurate diagnosis and effective management, adhering to the principles of emergency medical practice? Option A. Immediately administer empiric treatments such as intravenous fluids and glucose, assuming a metabolic cause for the altered mental status. Option B. Rely on the patient's ability to respond to simple verbal commands as the sole indicator of their neurological status. Option C. Perform a detailed neurological examination, including the Glasgow Coma Scale, pupillary light reflex, and assessment of gross motor function, to establish a baseline and identify specific deficits. Option D. Prioritize securing the airway and initiating ventilatory support without a detailed neurological assessment, as this is the most immediate life-saving intervention. The correct answer is C. Perform a detailed neurological examination, including the Glasgow Coma Scale, pupillary light reflex, and assessment of gross motor function, to establish a baseline and identify specific deficits. Explanation. This scenario presents a professionally challenging situation due to the inherent uncertainty in assessing consciousness and neurological status in a critically ill patient. The emergency physician must balance the need for rapid intervention with the imperative to accurately diagnose and manage the patient's condition, all while adhering to established medical standards and ethical obligations. The dynamic nature of neurological compromise, coupled with potential confounding factors like intoxication or metabolic derangements, necessitates a systematic and thorough approach. The correct approach represents best professional practice because it prioritizes a comprehensive neurological assessment, including the Glasgow Coma Scale, GCS, pupillary response, and gross motor function, as a foundational step in evaluating altered mental status. This systematic evaluation, guided by established protocols and clinical judgment, allows for objective baseline documentation and facilitates the identification of specific neurological deficits. This aligns with the American Board of Emergency Medicine's emphasis on evidence-based practice and the physician's duty to provide competent care, ensuring that diagnostic and therapeutic decisions are informed by accurate patient assessment. Furthermore, it supports the ethical principle of beneficence by aiming to identify and address the underlying cause of the neurological change promptly and effectively. An incorrect approach that relies solely on a superficial observation of the patient's responsiveness without a structured neurological examination fails to meet professional standards. This approach risks overlooking subtle but significant neurological deficits, potentially leading to delayed or inappropriate management. Ethically, this constitutes a failure in the duty of care, as it deviates from the expected standard of thoroughness in patient assessment. Another incorrect approach that focuses exclusively on immediate interventions like airway management, without a concurrent or preceding neurological assessment, while potentially life-saving in certain contexts, can be problematic if it delays the critical diagnostic process. While airway protection is paramount, a comprehensive neurological assessment is essential for guiding further management beyond immediate stabilization. This approach could be seen as a failure to fully investigate the underlying cause, potentially leading to suboptimal long-term outcomes. A third incorrect approach that involves prematurely attributing altered consciousness to a single, unconfirmed cause, such as intoxication, without a systematic neurological workup, is ethically and professionally unsound. This premature closure of diagnostic reasoning can lead to misdiagnoses of more serious conditions like stroke, intracranial hemorrhage, or metabolic emergencies. It violates the principle of non-maleficence by potentially withholding necessary treatment for the true underlying pathology. The professional decision-making process for similar situations should involve a systematic approach. 1. Initial rapid assessment for immediate life threats, ABCs. 2. Structured neurological examination, including GCS, pupillary assessment, and motor/sensory function. 3. Consideration of differential diagnoses based on the patient's history, presentation, and initial assessment. 4. Targeted investigations, e.g., imaging, laboratory tests, to confirm or refute differential diagnoses. 5. Reassessment of the patient's neurological status throughout the encounter. 6. Clear documentation of all findings and interventions. Question 4. Risk assessment procedures indicate a need to evaluate the historical underpinnings of emergency medicine's establishment as a recognized medical specialty in the United States, a process that directly informs the standards set by the American Board of Emergency Medicine. Which of the following best describes a primary driver in the formalization of emergency medicine as a distinct specialty? Option A. The development of standardized residency training programs and the subsequent establishment of board certification in emergency medicine. Option B. The emergence of professional organizations advocating for physician autonomy in all areas of medical practice. Option C. The widespread adoption of advanced diagnostic imaging technologies in the 1970s, necessitating a more specialized approach to patient assessment. Option D. The increasing volume of trauma cases following major national disasters, requiring dedicated physician expertise. The correct answer is C. The widespread adoption of advanced diagnostic imaging technologies in the 1970s, necessitating a more specialized approach to patient assessment. Explanation. This scenario presents a challenge in understanding the foundational principles of emergency medicine's development within the U.S. regulatory and professional landscape, specifically as it relates to the American Board of Emergency Medicine, ABEM, certification. Question probes the historical context of how emergency medicine evolved from a less formalized practice to a recognized specialty. The correct approach requires an understanding of the key milestones and driving forces behind the formalization of emergency medicine as a specialty in the United States. This includes the recognition of the need for standardized training, board certification, and the establishment of emergency medicine as a distinct medical discipline. This aligns with the ABEM mission to ensure high-quality patient care by setting standards for physicians practicing emergency medicine. An incorrect approach would involve misattributing the primary drivers of emergency medicine's evolution or misunderstanding the timeline of its formalization. For instance, focusing solely on the development of specific technologies without acknowledging the broader professional and organizational efforts would be a failure. Similarly, suggesting that emergency medicine emerged as a specialty without significant advocacy, research, and the establishment of formal training pathways would be inaccurate and fail to reflect the historical reality that ABEM certification is built upon. Regulatory and ethical failures in incorrect approaches would stem from a lack of appreciation for the systematic efforts to professionalize the field, which ultimately underpins the credibility and standards of ABEM certification. Professionals should approach such questions by recalling the historical trajectory of emergency medicine, recognizing the pivotal role of organizations and individuals who championed its development as a distinct specialty. This involves understanding the transition from a service provided by various physicians to a recognized academic and clinical discipline with defined training and certification requirements, as embodied by ABEM. Question 5. Cost-benefit analysis shows that while on-scene time is a factor in trauma care, the primary determinant for transport destination in a hemodynamically unstable patient with suspected severe injuries should be the availability of definitive care. Considering a patient with multiple penetrating torso injuries, significant hypotension, and altered mental status, which of the following transport decisions best aligns with established trauma management principles and regulatory frameworks for emergency medical services? Option A. Immediate transport to the closest hospital, regardless of trauma center designation, to minimize scene time. Option B. Transport to a level I trauma center, initiating advanced resuscitation measures en route as the patient's condition warrants definitive surgical intervention. Option C. Transport to a community hospital with a general surgery department, but no specific trauma designation, as it is geographically closer than a level I trauma center. Option D. On-scene extrication and stabilization for an extended period to complete a full secondary survey and administer all possible interventions before transport. The correct answer is A. Immediate transport to the closest hospital, regardless of trauma center designation, to minimize scene time. Explanation. This scenario presents a common challenge in emergency medicine, balancing the immediate need for definitive trauma care with the logistical and resource constraints of a pre-hospital setting, all while adhering to established protocols and patient safety guidelines. The professionally challenging aspect lies in making rapid, informed decisions under pressure, where suboptimal choices can have significant patient outcomes. Careful judgment is required to assess the patient's stability, the capabilities of the receiving facility, and the potential benefits versus risks of immediate transport versus on-scene stabilization. The correct approach represents best professional practice by prioritizing patient safety and adherence to the American Board of Emergency Medicine, ABEM, guidelines for trauma assessment and management. This involves a systematic evaluation of the patient's condition, including a primary and secondary survey, and a rapid assessment of the need for immediate intervention. The decision to transport to a level I trauma center is justified by the patient's hemodynamic instability and suspected severe injuries, which align with the criteria for activation of trauma protocols and direct transport to the highest level of care available. This approach ensures that the patient receives the most appropriate and timely definitive care, minimizing the risk of deterioration. An incorrect approach that involves delaying transport to perform extensive on-scene procedures not critical for immediate stabilization would be a regulatory and ethical failure. This could violate ABEM guidelines by prolonging transport time unnecessarily, potentially leading to further patient compromise. It also fails to recognize the limitations of pre-hospital care and the critical need for definitive surgical or interventional capabilities available at a trauma center. Another incorrect approach, such as transporting to the closest hospital not equipped for major trauma, would be a failure to adhere to established trauma triage criteria, potentially resulting in delayed definitive care and adverse patient outcomes, which is contrary to the principles of effective trauma management. The professional decision-making process for similar situations should involve a rapid, systematic assessment of the patient's ABCs, airway, breathing, circulation, and neurological status. This should be followed by a quick secondary survey to identify obvious injuries. The clinician must then consider the mechanism of injury, the patient's vital signs, and the presence of any load-and-go conditions. Consultation with medical control or a trauma center is often crucial for guidance on the most appropriate destination and management strategy. The decision should always be guided by the principle of providing the patient with the best chance of survival and recovery, which often means rapid transport to a facility capable of definitive care. Question 6. The analysis reveals a 65-year-old male presenting to the emergency department with severe abdominal pain, diaphoresis, and hypotension, BP 80/40 mmHg, with a heart rate of 130 bpm. Initial assessment suggests significant hypovolemia. Which of the following represents the most appropriate initial management strategy for intravenous access and fluid resuscitation? Option A. Administer a vasopressor infusion while awaiting further diagnostic imaging. Option B. Place a central venous catheter for fluid administration. Option C. Secure 2 large-bore intravenous lines and begin rapid infusion of isotonic crystalloid solution. Option D. Obtain a complete blood count and chemistry panel before initiating any fluid resuscitation. The correct answer is C. Secure 2 large-bore intravenous lines and begin rapid infusion of isotonic crystalloid solution. Explanation. This scenario presents a common yet critical challenge in emergency medicine, rapidly assessing and initiating appropriate resuscitation for a patient with suspected hypovolemic shock. The professional challenge lies in the need for swift, decisive action based on limited initial data, while simultaneously adhering to established protocols and patient safety principles. The urgency of the situation demands a structured approach to intravenous access and fluid resuscitation to prevent further hemodynamic compromise and organ damage. The correct approach prioritizes establishing adequate intravenous access and initiating rapid fluid resuscitation, aligning with established American Board of Emergency Medicine, ABEM, guidelines and general principles of emergency care. This is best professional practice because prompt volume replacement is paramount in reversing hypovolemic shock, improving tissue perfusion, and stabilizing the patient. The ABEM emphasizes evidence-based resuscitation strategies, and in the absence of contraindications, rapid infusion of crystalloids is the cornerstone of initial management for hypovolemic shock. This approach directly addresses the underlying pathophysiology by restoring intravascular volume. An incorrect approach would be to delay intravenous access or fluid administration while awaiting further diagnostic tests or specialist consultation. This failure constitutes a significant regulatory and ethical lapse. From a regulatory standpoint, it violates the duty of care to provide timely and appropriate medical intervention. Ethically, it represents a failure to act in the patient's best interest, potentially leading to preventable harm or death. Another incorrect approach would be to administer fluids too slowly or to use inappropriate fluid types without clear indication, which would also fail to address the immediate hemodynamic deficit effectively and could be considered a deviation from standard of care. Professionals should employ a decision-making framework that begins with rapid primary survey (UPDE), followed by a focused history and physical examination to identify signs of shock. Based on these findings, immediate interventions such as securing large-bore intravenous access and initiating rapid fluid boluses should be implemented. This framework prioritizes life-saving measures, with diagnostic workup proceeding concurrently or immediately thereafter, ensuring that patient stabilization is not compromised by diagnostic delays. Question 7. The assessment process reveals a 65-year-old male presenting with acute onset shortness of breath, pleuritic chest pain, and mild hemoptysis. His medical history is significant for hypertension and a recent long-distance flight. Initial vital signs show tachycardia and tachypnea, with a normal oxygen saturation on room air. He has a history of smoking, but denies any known lung disease. Which of the following diagnostic and management strategies best reflects a comprehensive approach to this patient's presentation in the emergency department? Option A. Administer bronchodilators and systemic corticosteroids and obtain a chest X-ray to rule out pneumonia. Option B. Initiate immediate intubation and mechanical ventilation due to the severity of his respiratory distress. Option C. Obtain an electrocardiogram (ECG), a chest X-ray, and consider a D-dimer test or CT pulmonary angiography based on clinical suspicion for pulmonary embolism. Option D. Provide supplemental oxygen and observe the patient for improvement, assuming a benign cause of his symptoms. Correct answer is A. Administer bronchodilators and systemic corticosteroids and obtain a chest X-ray to rule out pneumonia. Explanation: this scenario presents a common yet critical challenge in emergency medicine, differentiating between acute exacerbations of chronic respiratory conditions and other life-threatening causes of dyspnea. The professional challenge lies in the overlapping symptomatology and the need for rapid, accurate diagnosis to initiate appropriate, potentially life-saving treatment while avoiding unnecessary or harmful interventions. The urgency of respiratory distress demands swift action, but misdiagnosis can lead to delayed definitive care or iatrogenic harm. The correct approach represents best professional practice by prioritizing a systematic diagnostic workup that considers the most likely and most dangerous etiologies. This aligns with the American Board of Emergency Medicine's emphasis on evidence-based medicine and patient safety, which are foundational to the practice of emergency medicine. Specifically, a structured approach that includes a thorough history, physical examination, targeted investigations like ECG and chest imaging, and consideration of biomarkers is crucial for differentiating between asthma, COPD exacerbation, and pulmonary embolism. This methodical process ensures that the patient receives the most appropriate care based on their specific clinical presentation and risk factors, adhering to established clinical guidelines and the ethical obligation to provide competent care. An incorrect approach that solely focuses on treating presumed asthma or COPD without adequately considering pulmonary embolism is a significant regulatory and ethical failure. This failure stems from a violation of the principle of do no harm, non-maleficence, by potentially delaying diagnosis and treatment of a life-threatening condition like PE. Ethically, it represents a departure from due diligence and a failure to provide a comprehensive assessment. From a regulatory standpoint, it could be viewed as a deviation from accepted standards of care, potentially leading to adverse patient outcomes and professional repercussions. Similarly, an approach that prematurely dismisses PE based on a single negative finding, without considering the full clinical picture or alternative diagnostic strategies, also falls short. This demonstrates a lack of critical thinking and adherence to a comprehensive diagnostic algorithm, which is expected in emergency medicine practice. The professional decision-making process for similar situations should involve a rapid initial assessment to determine the severity of respiratory distress and the need for immediate life support. This is followed by a systematic differential diagnosis, considering the most common and most dangerous causes. The clinician must then utilize available diagnostic tools judiciously, integrating clinical findings with test results to arrive at the most probable diagnosis. This iterative process of assessment, diagnosis, and treatment adjustment is essential for managing complex respiratory emergencies effectively and ethically. Question 8. Research into a patient experiencing sudden cardiac arrest reveals that the patient's spouse is present and states, "He would never want this. He told me years ago he didn't want to be kept alive by machines." The patient is pulseless and apneic, and the emergency medical system has initiated basic life support. As the attending physician in the emergency department, what is the most appropriate immediate course of action regarding advanced cardiac life support, ACLS protocols? Option A. Immediately initiate ACLS protocols as per established guidelines, while simultaneously engaging the spouse in a detailed discussion to clarify the patient's wishes and the specifics of any advance directive. Option B. Cease all resuscitation efforts immediately based on the spouse's statement, assuming it accurately reflects the patient's wishes. Option C. Proceed with full ACLS interventions without further discussion with the spouse, as the patient is in cardiac arrest and the protocol dictates immediate action. Option D. Delay ACLS initiation to conduct a thorough investigation into the validity and scope of the spouse's claim regarding the patient's wishes. Correct answer is A. Immediately initiate ACLS protocols as per established guidelines, while simultaneously engaging the spouse in a detailed discussion to clarify the patient's wishes and the specifics of any advance directive. Explanation. This scenario presents a common yet ethically complex situation in emergency medicine, specifically within the context of advanced cardiac life support ACLS protocols. The challenge lies in balancing the patient's presumed wishes, as communicated by a family member, with the immediate need for life-saving interventions and the established ACLS guidelines. The physician must navigate potential conflicts between surrogate decision-makers and the standard of care, all while operating under time-sensitive conditions. The correct approach prioritizes the patient's immediate medical needs as dictated by ACLS protocols, while simultaneously seeking to honor the patient's previously expressed wishes. This involves initiating ACLS promptly to preserve life and organ function, as per established guidelines, while also engaging in a sensitive and thorough discussion with the family to understand the nature and reliability of the patient's advance directives or prior statements. This approach upholds the ethical principles of beneficence, acting in the patient's best interest, and respect for autonomy, honoring the patient's wishes, even when those wishes are communicated indirectly. It aligns with the spirit of ACLS, which aims to restore life, but also acknowledges the importance of patient-centered care and shared decision-making when possible. An incorrect approach that immediately ceases resuscitation efforts based solely on a family member's statement, without verifying the existence or clarity of an advance directive or engaging in a more comprehensive discussion about the patient's wishes, fails to adhere to the fundamental principles of ACLS. This could be considered a failure of beneficence, as potentially life-saving interventions are withheld prematurely. It also risks violating the patient's autonomy if their prior wishes were not accurately or fully represented by the family member, or if the family member's interpretation is biased. Furthermore, failing to document the discussion and the rationale for any decision to withdraw care can lead to regulatory and legal complications, as well as ethical breaches related to transparency and accountability. Another incorrect approach would be to proceed with aggressive ACLS without any attempt to ascertain or respect the patient's wishes, even if a family member is present and claims to know them. While ACLS is the standard of care in cardiac arrest, ignoring a known or suspected advance directive, if reliably communicated, can be an ethical failure to respect patient autonomy. This approach prioritizes the protocol over the individual patient's values and preferences, which is contrary to modern ethical medical practice. A professional decision-making process in such situations should involve a rapid assessment of the patient's medical status and the immediate need for ACLS. Concurrently, the physician should actively and respectfully engage with the family or surrogate to gather information about the patient's wishes, including any existing advance directives, durable power of attorney for healthcare, or clear verbal statements made prior to incapacitation. If there is ambiguity or conflict, the physician should seek clarification, potentially involving ethics committees or legal counsel if the situation is complex or prolonged. The ultimate decision should be a balance between the medical urgency, established protocols, and the patient's known or presumed values, with clear documentation of all discussions and decisions. Question 9. Examination of the data shows a 45-year-old male presenting to the emergency department with a 24-hour history of severe, diffuse abdominal pain, nausea, and vomiting. Vital signs are stable. Physical examination reveals diffuse abdominal tenderness without rebound or guarding, and hypoactive bowel sounds. Initial laboratory results show a mild leukocytosis and elevated amylase and lipase levels. Which of the following diagnostic and management strategies best reflects the immediate priorities for this patient? Option A. Initiate broad-spectrum antibiotics, obtain a contrast-enhanced CT scan of the abdomen and pelvis, and consult general surgery for evaluation of potential appendicitis or bowel obstruction. Option B. Provide symptomatic treatment with antiemetics and pain medication. Schedule outpatient follow-up with gastroenterology in 1 week and repeat lipase levels at that time. Option C. Administer intravenous fluids and analgesia, obtain a complete abdominal ultrasound, and await further laboratory results before considering surgical consultation. Option D. Focus on conservative management with bowel rest and nasogastric tube decompression, and reevaluate in 48 hours if symptoms do not improve significantly. The correct answer is C. Administer intravenous fluids and analgesia, obtain a complete abdominal ultrasound, and await further laboratory results before considering surgical consultation. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medicine, where a patient exhibits symptoms that could be attributed to several serious gastrointestinal emergencies. The difficulty lies in differentiating between conditions that require immediate surgical intervention, like appendicitis or bowel obstruction, and those that may be managed medically, like pancreatitis, though severe cases can also require surgical consultation. The urgency of the situation, the potential for rapid deterioration, and the need for accurate diagnosis to guide appropriate management make this a professionally challenging case. Misdiagnosis or delayed diagnosis can lead to significant morbidity and mortality. Correct approach analysis. The correct approach prioritizes a systematic diagnostic process that includes a thorough history, physical examination, and targeted investigations. This aligns with the American Board of Emergency Medicine's emphasis on evidence-based practice and patient safety. A comprehensive evaluation, including laboratory studies, CBC, CMP, lipase, amylase, imaging, ultrasound, CT scan, and consideration of surgical consultation based on initial findings, is crucial for accurate diagnosis and timely intervention. This approach ensures that the patient receives the most appropriate care, minimizing risks associated with delayed treatment or unnecessary procedures. Adherence to established diagnostic pathways and consultation protocols is a cornerstone of professional practice in emergency medicine. Incorrect approaches analysis. One incorrect approach involves relying solely on a single diagnostic modality or symptom without a comprehensive workup. For instance, assuming a diagnosis based on elevated amylase and lipase alone, without considering other causes of abdominal pain, or ruling out surgical emergencies like appendicitis or obstruction, would be a significant failure. This violates the principle of thoroughness and can lead to misdiagnoses. Another incorrect approach is to delay definitive imaging or surgical consultation while pursuing less critical investigations. In cases of suspected bowel obstruction or appendicitis, time is of the essence. Procrastinating on obtaining a CT scan or consulting surgery while waiting for less urgent lab results could lead to complications such as perforation or sepsis, representing a failure to adhere to time-sensitive management protocols and potentially violating standards of care. A third incorrect approach would be to discharge a patient with concerning abdominal pain and signs suggestive of a serious gastrointestinal emergency without adequate diagnostic evaluation or a clear plan for follow-up. This poses a direct risk to patient safety and contravenes the ethical obligation to provide appropriate care, potentially leading to severe adverse outcomes if the underlying condition is not identified and treated. Professional reasoning. Professionals should approach such cases by first establishing a broad differential diagnosis based on the patient's presentation. This is followed by a systematic gathering of information through history and physical exam, guiding the selection of appropriate diagnostic tests. The results of these tests should be interpreted in the context of the differential, and a definitive diagnosis or a refined differential should be established. Crucially, the decision-making process must incorporate the urgency of the suspected conditions and the need for timely intervention, including appropriate consultations with surgical or other specialists. This iterative process of assessment, investigation, and reassessment ensures that patient care is optimized and risks are minimized. Question 10. The monitoring system demonstrates a patient presenting with sudden onset of severe abdominal pain, nausea, and diaphoresis. The emergency physician's initial assessment must prioritize differentiating between conditions requiring immediate life-saving intervention and those that can be managed with less urgency, strictly adhering to the definition and scope of emergency medicine as defined by the American Board of Emergency Medicine. Which of the following approaches best reflects the scope of emergency medicine in this scenario? Option A. Immediately transfer the patient to an inpatient bed for further management without initiating any diagnostic workup, assuming the condition is not immediately life-threatening. Option B. Initiate a comprehensive diagnostic workup including imaging and laboratory studies to rule out a broad differential, prioritizing immediate stabilization and treatment of any identified emergent conditions. Option C. Focus on managing the patient's symptoms with analgesics and antiemetics while awaiting a scheduled appointment with a gastroenterologist for further evaluation. Option D. Advise the patient to return if symptoms worsen significantly, as the initial presentation does not definitively indicate a life-threatening emergency. The correct answer is B. Initiate a comprehensive diagnostic workup including imaging and laboratory studies to rule out a broad differential, prioritizing immediate stabilization and treatment of any identified emergent conditions. Explanation. The monitoring system demonstrates a patient presenting with symptoms that could be attributed to a wide range of conditions, some emergent and others less so. This scenario is professionally challenging because it requires the emergency physician to rapidly differentiate between life-threatening emergencies and conditions that can be managed with less immediate intervention, all within the defined scope of emergency medicine, as per the American Board of Emergency Medicine, ABEM, guidelines. The core of emergency medicine lies in the immediate assessment and treatment of acute illness and injury. The correct approach represents best professional practice because it aligns with the ABEM definition of emergency medicine, which encompasses the diagnosis and treatment of undifferentiated symptoms and signs of disease and injury. This includes conditions that are life-threatening or could result in significant morbidity if not promptly addressed. The physician's responsibility is to stabilize the patient and initiate appropriate diagnostic and therapeutic measures, recognizing that the emergency department is the front line for acute care. An incorrect approach that focuses solely on non-emergent differential diagnoses fails to meet the fundamental obligation of emergency medicine to address potential life threats. This would be a regulatory and ethical failure, as it neglects the primary purpose of the emergency department. Another incorrect approach that involves delaying definitive care or transferring the patient without adequate stabilization would also be a failure, as it contravenes the principle of providing immediate and appropriate care for acute conditions. Furthermore, an approach that dismisses the patient's symptoms without a thorough, albeit rapid, evaluation would violate the ethical duty of care and the professional standards of emergency medicine. Professionals should employ a systematic approach to patient assessment, prioritizing the identification and management of life-threatening conditions. This involves a rapid history and physical examination, followed by judicious use of diagnostic tools, all within the context of the patient's presenting complaint and the capabilities of the emergency department. The decision-making process should be guided by the principles of emergency medicine, focusing on the acuity and potential severity of the patient's condition. Question 11. To address the challenge of a hypotensive, obtunded patient presenting with abdominal pain and a history of type 1 diabetes, where the initial differential diagnosis includes diabetic ketoacidosis and adrenal crisis, what is the most appropriate initial management strategy? Option A. Administer empiric high-dose corticosteroids and intravenous fluids while awaiting laboratory confirmation of adrenal insufficiency. Option B. Initiate intravenous insulin infusion immediately to address potential hyperglycemia and acidosis while closely monitoring vital signs. Option C. Administer intravenous fluids, obtain stat laboratory investigations including glucose, electrolytes, renal function, and blood gas analysis, and draw baseline cortisol levels prior to any specific hormonal therapy. Option D. Withhold intravenous fluids until a definitive diagnosis of either diabetic ketoacidosis or adrenal crisis is established by laboratory results. The correct answer is C. Administer intravenous fluids, obtain stat laboratory investigations including glucose, electrolytes, renal function, and blood gas analysis, and draw baseline cortisol levels prior to any specific hormonal therapy. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the rapid decompensation of a patient with suspected diabetic ketoacidosis, DKA, or adrenal crisis. The urgency of these conditions necessitates swift and accurate diagnostic and therapeutic interventions. The challenge lies in differentiating between these two life-threatening endocrine emergencies as their management, while sharing some similarities, e.g., fluid resuscitation, diverges significantly in critical aspects like the use of insulin and corticosteroid replacement. Misdiagnosis can lead to delayed or inappropriate treatment, exacerbating the patient's condition and potentially leading to irreversible harm or death. The need for immediate assessment and intervention under pressure, with potentially limited initial information, underscores the importance of a systematic and evidence-based approach. Correct approach analysis. The correct approach prioritizes immediate stabilization and diagnostic evaluation to guide definitive management. This involves initiating broad-spectrum supportive care, including aggressive intravenous fluid resuscitation to address hypovolemia and correct electrolyte imbalances, which is crucial for both DKA and adrenal crisis. Simultaneously, obtaining essential laboratory investigations is paramount. Key among these are serum glucose, electrolytes, including potassium and sodium, arterial or venous blood gas analysis to assess for acidosis, serum ketones or urine ketones, and renal function tests. Crucially, for suspected adrenal crisis, obtaining baseline cortisol levels and ACT stimulation testing, if feasible and not unduly delaying treatment, are vital. In the context of DKA, the presence of hyperglycemia, ketosis, and metabolic acidosis, coupled with a normal or low cortisol, would strongly suggest DKA. Conversely, a profoundly ill patient with hyponatremia, hyperkalemia, hypoglycemia, or normoglycemia, and a low or inappropriately normal cortisol level, especially in the setting of stress or recent steroid withdrawal, would point towards adrenal crisis. The American Board of Emergency Medicine, ABEM, guidelines emphasize a structured approach to undifferentiated critically ill patients, prioritizing life-saving interventions while concurrently pursuing diagnostic clarity. Prompt recognition and initiation of appropriate management, guided by these initial investigations, represent best professional practice, aligning with the ABEM commitment to evidence-based emergency medicine and patient safety. Incorrect approaches analysis. Administering insulin therapy without confirming hyperglycemia and ketosis, or before ruling out adrenal crisis, represents a significant regulatory and ethical failure. In adrenal crisis, insulin can precipitate profound hypoglycemia and worsen the hemodynamic instability, directly contravening the principle of do no harm, non-maleficence. This approach bypasses essential diagnostic steps, leading to potentially catastrophic consequences. Delaying fluid resuscitation while awaiting definitive diagnostic confirmation, particularly in a hypotensive patient, is another critical failure. Both DKA and adrenal crisis can lead to severe hypovolemia and shock. Withholding or significantly delaying fluid resuscitation violates the ethical obligation to provide timely and necessary supportive care, potentially leading to organ damage and increased morbidity and mortality. This demonstrates a lack of adherence to established emergency management protocols for critically ill patients. Initiating empiric corticosteroid therapy without considering the possibility of DKA is also problematic, though less immediately dangerous than inappropriate insulin administration. While corticosteroids are essential for adrenal crisis, their use in DKA is generally not indicated unless there is a coexisting adrenal insufficiency or refractory DKA. Unnecessary steroid administration can mask underlying conditions or contribute to complications in certain patient populations, representing a deviation from precise diagnostic and therapeutic pathways. Professional reasoning. Professionals should approach such undifferentiated critically ill patients with a high index of suspicion for life-threatening endocrine emergencies. The decision-making process should involve rapid assessment of the ABCs, airway, breathing, circulation, followed by immediate initiation of supportive measures like fluid resuscitation. Concurrently, a focused history and physical examination should be performed to elicit clues suggestive of DKA, e.g., polyuria, polydipsia, abdominal pain, Kussmaul respirations, or adrenal crisis, e.g., history of adrenal insufficiency, recent steroid use, symptoms of dehydration, hypotension refractory to fluids, hyponatremia, hyperkalemia. The prompt ordering of targeted laboratory tests is crucial for differentiating these conditions. The principle of first do no harm dictates that interventions should be guided by diagnostic information, and empiric treatment should only be initiated when there is a clear and immediate life threat that outweighs the risks of delayed diagnosis. In cases of diagnostic uncertainty, where both conditions are strongly suspected and the patient is unstable, a balanced approach, such as initiating fluids and considering empiric low-dose corticosteroids while awaiting definitive labs, may be warranted, but this must be a carefully considered decision based on the overall clinical picture and risk-benefit analysis. Question 12. Analysis of the utility of point-of-care ultrasound POCUS in the emergency department for a patient presenting with undifferentiated hypotension and altered mental status, considering the need for rapid diagnosis and management. Which of the following approaches best reflects the appropriate application of POCUS in this critical scenario, adhering to emergency medicine practice standards? Option A. Relying solely on laboratory investigations and traditional imaging modalities, deferring any ultrasound assessment until the patient is stabilized and transferred to a different service. Option B. Performing a detailed musculoskeletal ultrasound of the extremities to rule out occult fractures or soft tissue injuries as a potential cause of the patient's hypotension. Option C. Forming a focused cardiac ultrasound echocardiogram to assess for global systolic function, pericardial effusion, and right heart strain, alongside a focused abdominal ultrasound, fast exam, to evaluate for intra-abdominal hemorrhage. Option D. Conducting a comprehensive abdominal ultrasound survey to meticulously examine all abdominal organs for any subtle abnormalities, regardless of their immediate clinical relevance. Correct answer is C. Performing a focused cardiac ultrasound echocardiogram to assess for global systolic function, pericardial effusion, and right heart strain, alongside a focused abdominal ultrasound, fast exam, to evaluate for intra-abdominal hemorrhage. Explanation. This scenario presents a common challenge in emergency medicine where rapid diagnostic capabilities are crucial, but resource limitations and varying levels of expertise can influence the choice of diagnostic tools. The professional challenge lies in selecting the most appropriate ultrasound application for a specific clinical presentation, balancing diagnostic yield, patient safety, and the efficient use of emergency department resources, all within the established scope of practice for emergency physicians. The correct approach represents best professional practice because it aligns with the established guidelines and training competencies for emergency ultrasound as recognized by the American Board of Emergency Medicine, ABEM. This approach prioritizes a focused, goal-directed ultrasound examination that directly addresses the most likely life-threatening conditions based on the patient's presentation. It demonstrates an understanding of the limitations and strengths of point-of-care ultrasound, POCUS, in the emergency setting, emphasizing its role in rapid assessment and management rather than as a definitive diagnostic tool for all conditions. Adherence to these principles ensures patient safety and efficient care delivery, reflecting the core tenets of emergency medicine practice. An incorrect approach that relies on a broad, nonspecific ultrasound survey without a clear clinical question fails to adhere to the principles of goal-directed POCUS. This can lead to inefficient use of time and resources, potentially delaying critical interventions for the actual underlying pathology. Ethically, it may also represent a failure to provide timely and appropriate care if the physician is performing an examination that is unlikely to yield the necessary information quickly. Another incorrect approach that involves performing advanced ultrasound techniques beyond the scope of emergency physician training and competency is a significant regulatory and ethical failure. This could lead to misinterpretation of findings, delayed or incorrect diagnoses, and potential patient harm. It violates the principle of practicing within one's scope of expertise and could be considered a breach of professional standards and potentially malpractice. A further incorrect approach that defers all ultrasound examinations to radiology or other specialties without considering the immediate utility of POCUS for rapid assessment in the emergency department represents a missed opportunity for efficient patient care. While collaboration with other specialties is vital, the emergency physician's ability to perform POCUS for specific indications is a core competency designed to expedite diagnosis and management in critical situations. Failing to utilize this skill, when appropriate, can lead to delays in treatment and suboptimal patient outcomes, which is contrary to the ethical obligation to provide prompt and effective care. The professional decision-making process should involve a systematic evaluation of the patient's presentation, formulation of a differential diagnosis, and identification of the most critical conditions to rule out. Based on this, the emergency physician should then select the most appropriate POCUS application, e.g., fast exam for trauma, cardiac ultrasound for undifferentiated hypotension, lung ultrasound for dyspnea, that can rapidly provide actionable information to guide immediate management. This process emphasizes a problem-solving approach, leveraging POCUS as a tool to enhance, not replace, clinical judgment and the broader diagnostic workup. Question 13. The monitoring system demonstrates a slight but persistent increase in the patient's heart rate and a marginal decrease in their oxygen saturation over the past hour, despite no apparent change in their reported symptoms or physical examination findings. The patient is a 75-year-old male with a history of congestive heart failure and chronic obstructive pulmonary disease, currently admitted for pneumonia. Which of the following actions best reflects a comprehensive clinical assessment approach in this situation? Option A. Initiate a rapid sequence intubation protocol based on the trend of vital sign changes. Option B. Reassess the patient's clinical status with a focused physical examination, review recent medications and treatments, and consider potential underlying causes for the observed trends in conjunction with the patient's comorbidities. Option C. Continue routine monitoring without further intervention, assuming the changes are within acceptable variability for the patient's conditions. Option D. Immediately notify the patient's family to discuss potential transfer to the intensive care unit due to the observed vital sign trends. The correct answer is A. Initiate a rapid sequence intubation protocol based on the trend of vital sign changes. Explanation: this scenario presents a professionally challenging situation because it involves a patient with subtle but potentially critical changes in their vital signs, requiring a nuanced clinical assessment rather than a purely algorithmic approach. The challenge lies in distinguishing between benign fluctuations and early signs of deterioration that necessitate immediate intervention, balancing the risk of overtreatment with the imperative to prevent adverse outcomes. Careful judgment is required to integrate multiple data points, including patient history, physical examination findings, and monitoring data, to form a comprehensive clinical picture. The correct approach represents best professional practice because it prioritizes a thorough, individualized clinical assessment that goes beyond the immediate data displayed by the monitoring system. This aligns with the core principles of emergency medicine, which emphasize the physician's responsibility to synthesize all available information and apply clinical reasoning to determine the most appropriate course of action. Specifically, it adheres to the ABEM emphasis on the physician's ultimate responsibility for patient care and decision-making, as outlined in their guidelines regarding physician competency and patient management. This approach ensures that the patient's overall clinical status, not just isolated vital signs, guides management, thereby upholding the ethical obligation to provide patient-centered care and avoid diagnostic or therapeutic errors. An incorrect approach that relies solely on a predefined threshold for intervention, without considering the broader clinical context, represents a failure to exercise independent clinical judgment. This can lead to either unnecessary interventions, causing patient discomfort and resource utilization, or delayed recognition of true deterioration, potentially violating the physician's duty of care and leading to adverse patient outcomes. Such an approach may also be seen as a deviation from the expected standard of care, which mandates a comprehensive assessment by a qualified physician. Another incorrect approach that involves deferring critical decisions to nursing staff or automated alerts without direct physician oversight fails to meet the regulatory and ethical requirements of physician responsibility. While ancillary staff play a vital role, the ultimate responsibility for medical decision-making, especially in potentially critical situations, rests with the attending physician. This abdication of responsibility can lead to significant patient harm and is a direct contravention of the physician's role as defined by professional standards and regulatory bodies. A further incorrect approach that involves dismissing the observed changes as insignificant without a systematic evaluation of potential causes or implications is also professionally unacceptable. This demonstrates a lack of due diligence and a failure to adequately assess risk. Emergency physicians are trained to consider a broad differential diagnosis and to investigate subtle changes that could indicate serious underlying pathology. Ignoring such changes without a reasoned basis constitutes a failure to provide appropriate medical care. The professional decision-making process for similar situations should involve a systematic approach. First, acknowledging and documenting the observed changes. Second, considering the patient's baseline status and known comorbidities. Third, performing a focused physical examination to correlate with the monitoring data. Fourth, reviewing recent interventions and medications. Fifth, considering the differential diagnosis for the observed changes. And finally, formulating a management plan that is tailored to the individual patient's clinical status and risk profile, with continuous reassessment as needed. This iterative process ensures that decisions are evidence-based, patient-specific, and ethically sound. Question 14. Benchmark analysis indicates that a 65-year-old male presents to the emergency department with acute onset of severe substernal chest pain radiating to his left arm, accompanied by shortness of breath and diaphoresis. His vital signs are stable, but he appears anxious. What is the most appropriate initial physical examination approach to this patient? Option A. A thorough gastrointestinal examination, including palpation of the abdomen for tenderness, masses, and organomegaly. Option B. A focused cardiovascular and pulmonary examination, including auscultation of heart sounds and lung fields, palpation of peripheral pulses, and assessment for peripheral edema. Option C. A rapid, superficial head-to-toe survey to quickly identify any obvious external trauma or deformities. Option D. A detailed neurological examination to assess for focal deficits, cranial nerve function, and meningeal signs. The correct answer is B. A focused cardiovascular and pulmonary examination, including auscultation of heart sounds and lung fields, palpation of peripheral pulses, and assessment for peripheral edema. Explanation: scenario analysis. This scenario presents a common challenge in emergency medicine, where a patient exhibits signs and symptoms that could be attributed to multiple serious conditions. The critical element is the need for a systematic and thorough physical examination to differentiate between these possibilities, ensuring no life-threatening condition is missed. The pressure of a busy emergency department and the potential for rapid patient deterioration necessitate efficient yet comprehensive assessment skills. Correct approach analysis. A systematic head-to-toe physical examination, tailored to the patient's presenting complaints, is the cornerstone of best professional practice in emergency medicine. This approach, aligned with ABEM standards for clinical competence, ensures a comprehensive evaluation, specifically focusing on the cardiovascular and pulmonary systems when chest pain and shortness of breath are present, while also performing a general survey and neurological assessment, allows for the identification of key findings that can guide diagnosis and management. This methodical approach minimizes the risk of diagnostic error and adheres to the ethical obligation to provide appropriate and timely care. Incorrect approaches analysis. Failing to perform a complete cardiovascular examination, including auscultation of all valve areas and palpation of peripheral pulses, when chest pain is a primary complaint, represents a failure to adhere to established diagnostic protocols and could lead to the misdiagnosis of conditions like aortic dissection or pericarditis. This oversight violates the ethical duty to provide a thorough evaluation, focusing solely on the respiratory system and neglecting a detailed abdominal examination in a patient with diffuse abdominal pain and possible referred pain to the chest, risks missing diagnoses such as a ruptured abdominal aortic aneurysm or a perforated viscus, both of which are surgical emergencies. This selective examination is not in accordance with the comprehensive assessment expected in emergency medicine. Performing a superficial neurological examination without assessing for focal deficits, cranial nerve function, or meningeal signs, when the patient has altered mental status, could result in a misdiagnosis of stroke, subarachnoid hemorrhage, or meningitis, all of which require immediate intervention. This incomplete assessment falls short of the expected standard of care. Professional reasoning. Professionals should approach such a patient by first stabilizing any immediate life threats, then proceeding with a systematic physical examination that prioritizes systems related to the chief complaint, but does not exclude other potentially serious organ systems. A structured approach, such as a head-to-toe survey, ensures that all relevant areas are assessed. This process should be guided by the patient's history and vital signs, but should not be limited by them. The decision-making process involves continuous reassessment as new information is gathered through the examination and diagnostic testing. Question 15. What factors determine the appropriateness of providing emergency medical treatment to an unconscious patient who requires immediate intervention to prevent death or serious harm, when no surrogate decision-maker is immediately available? Option A. The physician's personal belief about the patient's likely wishes, regardless of any legal or ethical guidelines. Option B. The urgency of the medical intervention required to prevent imminent death or serious harm, and the patient's inability to provide informed consent due to their unconscious state. Option C. The availability of advanced medical technology to treat the condition, even if the patient's life is not immediately threatened. Option D. The presence of a family member who claims to know the patient's wishes, even if their legal authority to consent is not established. The correct answer is B. The urgency of the medical intervention required to prevent imminent death or serious harm, and the patient's inability to provide informed consent due to their unconscious state. Explanation. This scenario presents a significant ethical and professional challenge for an emergency physician. The core difficulty lies in balancing the patient's immediate need for potentially life-saving treatment with the legal and ethical obligation to obtain informed consent, especially when the patient's capacity to consent is in question. The physician must navigate the complex interplay of patient autonomy, beneficence, and the legal framework governing medical decision-making for incapacitated individuals. This requires a nuanced understanding of when implied consent is appropriate and the steps necessary to ensure the patient's best interests are served while respecting their presumed wishes. The correct approach prioritizes patient safety and well-being while adhering to established ethical and legal principles. In an emergency situation where a patient is unable to communicate their wishes and requires immediate intervention to prevent serious harm or death, the law generally presumes implied consent for necessary treatment. This presumption is based on the ethical principle of beneficence and the reasonable assumption that a person would consent to life-saving measures if they were able to do so. The physician's duty is to act in the patient's best interest, which in this context means providing the critical care needed. Documenting the assessment of incapacity and the rationale for proceeding without explicit consent is crucial for legal and professional accountability. An incorrect approach would be to delay or withhold necessary emergency treatment due to the inability to obtain explicit informed consent. This failure to act would violate the physician's duty of beneficence and could lead to severe harm or death, constituting a breach of the standard of care. Another incorrect approach would be to proceed with treatment without attempting to ascertain the patient's wishes or without documenting the assessment of their incapacity. This could be seen as a violation of patient autonomy, even in an emergency, and could lead to legal repercussions if the patient's family later disputes the treatment. Furthermore, relying solely on the presence of a family member to provide consent without a thorough assessment of the patient's capacity or the family's legal authority to make decisions could also be problematic. The legal framework in the U.S. emphasizes the patient's right to self-determination, and while emergency exceptions exist, they are not a license to disregard the process of assessing capacity and seeking surrogate decision-makers when possible. The professional decision-making process in such situations should involve a rapid assessment of the patient's medical condition and the urgency of intervention. Simultaneously, the physician must assess the patient's capacity to understand their condition, the proposed treatment, and the alternatives. If the patient is deemed incapacitated, the physician should make reasonable efforts to identify and consult with a surrogate decision-maker, e.g., family, legal guardian, if available and identifiable in a timely manner. If no surrogate is available, or if there is a significant delay in their arrival, and the patient's life or limb is in immediate danger, the physician is ethically and legally justified in providing life-saving treatment under the doctrine of implied consent, provided this is thoroughly documented. Question 16. Governance review demonstrates a situation where an unconscious patient presents to the emergency department with symptoms highly suggestive of an acute ischemic stroke. The patient has no identification and no family or friends are present. The medical team is unable to ascertain the patient's wishes regarding treatment or identify a legal surrogate decision maker. The physician believes that immediate administration of intravenous thrombolytic therapy is critical to improving the patient's neurological outcome. What is the most ethically and legally appropriate course of action? Option A. Administer intravenous thrombolytic therapy immediately, as the emergent nature of the condition and the patient's lack of capacity necessitate intervention to preserve life and prevent serious harm. With documentation of the emergent circumstances and efforts to identify a surrogate. Option B. Proceed with a highly invasive surgical intervention to address the suspected stroke without attempting to identify a surrogate or consult with hospital ethics or legal counsel, assuming the patient would want the most aggressive treatment. Option C. Delay administration of intravenous thrombolytic therapy until a legal surrogate decision-maker can be identified and provide informed consent, even if this delay risks significant neurological damage or death. Option D. Consult with the patient's primary care physician, if known, to obtain their opinion on the patient's likely wishes regarding thrombolytic therapy before proceeding with any treatment. The correct answer is A. Administer intravenous thrombolytic therapy immediately, as the emergent nature of the condition and the patient's lack of capacity necessitate intervention to preserve life and prevent serious harm, with documentation of the emergent circumstances and efforts to identify a surrogate. Explanation. Scenario analysis. This scenario presents a challenging ethical dilemma involving a patient with a suspected neurological emergency who lacks decision-making capacity and has no surrogate decision-maker readily available. The physician must balance the urgent need for potentially life-saving intervention with the patient's right to autonomy and the legal and ethical requirements for informed consent, even in emergent situations. The absence of a clear surrogate complicates the process of obtaining consent for treatment, necessitating a careful consideration of established ethical and legal frameworks. Correct approach analysis. The correct approach prioritizes the patient's presumed best interest and the principle of beneficence in the absence of explicit directives or a surrogate. In emergent situations where a patient lacks capacity and no surrogate is available, physicians are ethically and legally permitted to provide necessary treatment to preserve life or prevent serious harm. This is often guided by the concept of implied consent or the emergency exception to informed consent, which assumes that a reasonable person would consent to life-saving treatment in such circumstances. The physician's duty to act in the patient's best interest, as determined by medical judgment, is paramount. This aligns with the core tenets of medical ethics and the legal framework governing emergency medical care in the United States, which allows for necessary interventions to prevent imminent death or serious disability. Incorrect approaches analysis. One incorrect approach involves delaying or withholding necessary treatment due to the inability to obtain explicit informed consent from a surrogate. This failure violates the physician's duty to act beneficently and can lead to irreversible harm or death, directly contravening the emergency exception to informed consent. It also fails to acknowledge the legal and ethical allowance for physicians to act in the patient's presumed best interest when capacity is lacking and no surrogate is available. Another incorrect approach is to proceed with a highly invasive or experimental treatment without attempting to identify a surrogate or consult with ethics or legal counsel. While emergent treatment is permissible, the scope of intervention should be limited to what is medically necessary to stabilize the patient or prevent immediate harm. Overstepping these bounds without due diligence in seeking surrogate consent or exploring alternatives can lead to ethical and legal repercussions, potentially violating principles of non-maleficence and patient autonomy, even when capacity is compromised. A third incorrect approach is to unilaterally make decisions based on personal beliefs or assumptions about the patient's wishes without any objective medical or ethical justification. This disregards the established principles of medical ethics and the legal requirements for patient care, potentially leading to inappropriate treatment or a failure to provide necessary care. It bypasses the critical step of medical judgment and the ethical obligation to act in the patient's best interest. Professional reasoning. In situations involving neurological emergencies and impaired decision-making capacity without a surrogate, the professional decision-making process should involve a rapid assessment of the patient's medical status and the urgency of intervention. The physician must determine if the patient lacks capacity and if there is an immediate threat to life or limb. If both are true, the physician should proceed with medically necessary and appropriate treatment under the emergency exception to informed consent, documenting the rationale thoroughly. Simultaneously, efforts should be made to identify potential surrogates through hospital resources, social work, or legal channels. If the situation is not immediately life-threatening, or if there is time to do so, the physician should consult with hospital ethics committees or legal counsel to navigate complex consent issues and ensure adherence to all regulatory and ethical guidelines. Question 17. Regulatory review indicates that in the United States, when a patient presents to the emergency department in cardiac arrest, and the family reports that the patient previously expressed a clear desire to refuse resuscitation, what is the most appropriate initial course of action for the emergency physician? Option A. Pause resuscitation efforts and engage in a detailed conversation with the family to confirm the patient's wishes and the reliability of their report. Option B. Immediately initiate cardiopulmonary resuscitation, CPR, to preserve life, as the patient is in the emergency department. Option C. Assume the patient would want CPR given the critical nature of the situation, overriding the family's report in the absence of a written advance directive. Option D. Proceed with resuscitation, while simultaneously contacting the hospital's legal department for guidance. The correct answer is B. Immediately initiate cardiopulmonary resuscitation, CPR, to preserve life, as the patient is in the emergency department. Explanation. Scenario analysis. This scenario presents a common but ethically complex situation in emergency medicine. The challenge lies in balancing the immediate need to provide life-saving interventions with the patient's previously expressed wishes, especially when those wishes are not formally documented, but are known through reliable sources. The physician must navigate potential conflicts between surrogate decision-makers and the patient's presumed autonomy, all while adhering to established medical standards and legal requirements for end-of-life care and resuscitation. Correct approach analysis. The correct approach prioritizes respecting the patient's known wishes, even in the absence of a formal advance directive, when those wishes are clearly communicated and reliably conveyed by a surrogate. This aligns with the ethical principle of patient autonomy and the legal framework in the U.S. that recognizes the importance of patient self-determination. The physician's responsibility is to ascertain the patient's wishes as accurately as possible and act in accordance with them, provided they are not contrary to law or medical standards. In this case, seeking clarification from the family about the patient's prior statements regarding resuscitation is the most ethically sound and legally defensible course of action. This approach upholds the patient's right to refuse medical treatment, even life-sustaining treatment, and respects the role of the family in representing the patient's values. Incorrect approach is analysis. Initiating CPR without further inquiry, despite the family's report of the patient's wishes, would be a regulatory and ethical failure. It disregards the patient's autonomy and the information provided by a reliable surrogate, potentially leading to a futile and unwanted intervention. This action could violate the Emergency Medical Treatment and Labor Act, EMTALA, if not handled appropriately, and more importantly, it disrespects the patient's right to self-determination, a cornerstone of medical ethics and U.S. law. Consulting only the hospital's legal department, without first attempting to clarify the patient's wishes with the family, is an inefficient and potentially dismissive approach. A legal consultation is important. It should not preempt the physician's primary responsibility to gather information directly relevant to the patient's care and wishes. This delays the decision-making process and may create an adversarial dynamic unnecessarily. Assuming the patient would want CPR because they are in the emergency department and the situation is critical, without considering their prior statements, is a failure to uphold patient autonomy. The emergency department setting does not negate a patient's right to refuse treatment. This assumption prioritizes the physician's interpretation of the situation over the patient's known preferences, which is ethically and legally problematic. Professional reasoning. In situations involving potential resuscitation and conflicting information about patient wishes, the professional decision-making process should involve 1. Immediate assessment of the patient's clinical status and need for resuscitation. 2. Eliciting and verifying information about the patient's wishes from reliable sources, including family members or documented advance directives. 3. If wishes are unclear or contested, engaging in a structured discussion with the surrogate decision-maker, focusing on the patient's values, beliefs, and prior statements. 4. Consulting with ethics committees or legal counsel when significant ethical or legal dilemmas arise. 5. Documenting all discussions, assessments, and decisions thoroughly. 6. Acting in the best interest of the patient, which includes respecting their autonomy and previously expressed wishes. Question 18. Strategic planning requires a comprehensive approach to managing patients presenting with suspected toxicological emergencies. Given a patient with altered mental status and vital sign abnormalities following a potential ingestion of an unknown substance, what is the most appropriate initial management strategy to ensure patient safety and optimize outcomes? Option A. Administer a broad panel of antidotes for common overdose syndromes simultaneously to cover all potential toxicities. Option B. Initiate supportive care, including airway management, ventilation, and hemodynamic stabilization, while concurrently considering empiric treatment based on the patient's clinical presentation and known toxidromes, pending further diagnostic workup. Option C. Withhold all specific pharmacologic interventions until definitive laboratory confirmation of the ingested substance is obtained. Option D. Focus exclusively on symptomatic relief of vital sign abnormalities, without investigating the underlying cause or considering specific antidotes. The correct answer is B. Initiate supportive care, including airway management, ventilation, and hemodynamic stabilization, while concurrently considering empiric treatment based on the patient's clinical presentation and known toxidromes, pending further diagnostic workup. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in emergency medicine, managing a patient with a suspected overdose of an unknown substance. The professional challenge lies in the immediate need for effective treatment in the face of diagnostic uncertainty, potential for rapid deterioration, and the ethical imperative to provide care without delay while adhering to established protocols and patient safety. The physician must balance aggressive management with the avoidance of iatrogenic harm from inappropriate interventions. Correct approach analysis. The correct approach involves a systematic, evidence-based management strategy that prioritizes patient stabilization and addresses potential life threats. This aligns with the American Board of Emergency Medicine, ABEM guidelines, which emphasize a thorough history, physical examination, and targeted investigations to guide treatment. The use of empiric therapies for common overdose syndromes, e.g., anticholinergic, opioid, sedative, hypnotic, is a cornerstone of toxicology management when the specific agent is unknown, but this must be guided by clinical presentation and the availability of specific antidotes. The focus on supportive care, including airway management, ventilation, and hemodynamic support, is paramount and universally accepted in toxicological emergencies. This approach reflects the ABEM commitment to evidence-based practice and patient safety, ensuring that interventions are both timely and appropriate. Incorrect approach is analysis. One incorrect approach would be to withhold all specific treatment until a definitive diagnosis is established through laboratory testing. This fails to meet the standard of care in an acute overdose where delay can lead to irreversible harm or death. ABEM standards expect emergency physicians to initiate appropriate management based on clinical presentation and available evidence, not solely on definitive laboratory confirmation, which can be time-consuming. This approach represents a failure in timely intervention and patient advocacy. Another incorrect approach would be to administer a broad spectrum of antidotes without a clear clinical indication. For example, administering naloxone to a patient who is not opioid intoxicated or flumazenil to a patient with a mixed overdose or a history of seizure disorder can lead to significant adverse effects and mask the true underlying pathology. This demonstrates a lack of clinical judgment and a failure to adhere to the principle of first, do no harm, which is fundamental to medical practice and implicitly supported by ABEM emphasis on evidence-based and judicious use of interventions. A third incorrect approach would be to focus solely on symptomatic treatment without considering the potential for specific toxic effects that require targeted antidotes or interventions. While supportive care is crucial, ignoring the possibility of a readily reversible condition due to a specific toxin would be a significant oversight. This approach neglects the potential for rapid and complete recovery with appropriate pharmacologic reversal, a key aspect of effective toxicological management. Professional reasoning. In managing a suspected overdose, the emergency physician should employ a structured approach. First, ensure scene safety and personal protection if the substance is unknown or potentially hazardous. Second, perform a rapid primary survey of dead to identify and address immediate life threats. Third, obtain a focused history from the patient or collateral sources, including the suspected substance, amount, time of ingestion, and any co-ingestions. Fourth, conduct a thorough physical examination, looking for characteristic toxidromes. Fifth, initiate supportive care, including oxygen, intravenous access, cardiac monitoring, and pulse oximetry. Sixth, consider empiric treatment based on the clinical presentation and the availability of specific antidotes, always weighing the risks and benefits. Finally, arrange for appropriate laboratory investigations, recognizing that these may not be immediately available or may not guide initial management. This systematic process, grounded in clinical assessment and evidence-based principles, is essential for optimal patient outcomes in toxicological emergencies. Question 19. Compliance review shows a patient presenting to the emergency department with acute flank pain. The patient's chart indicates a history of opioid use disorder, currently managed with buprenorphine. The emergency physician must determine the most appropriate initial management strategy for the patient's pain. Which of the following approaches best aligns with current best practices and regulatory guidelines for emergency medicine in the United States? Option A. Administer intravenous hydromorphone 4 mg, reassessing pain in 30 minutes. Option B. Advise the patient that opioid pain medication cannot be provided due to their history of opioid use disorder and suggest they wait for their scheduled buprenorphine dose. Option C. Prescribe oral oxycodone 10 mg every 4 hours as needed for pain, with instructions to continue buprenorphine as prescribed. Option D. Initiate a multimodal pain management plan, including intravenous ketorolac and oral acetaminophen, with consideration for a low-dose opioid if pain remains severe after initial interventions. The correct answer is A. Administer intravenous hydromorphone 4 mg, reassessing pain in 30 minutes. Explanation. Scenario analysis. This scenario presents a common challenge in emergency medicine, managing acute pain in a patient with a history of opioid use disorder. The professional challenge lies in balancing the immediate need for pain relief with the risk of exacerbating the patient's underlying condition or triggering a relapse. It requires a nuanced approach that avoids both undertreatment of pain and inappropriate escalation of opioid therapy. Correct approach analysis. The correct approach prioritizes a comprehensive pain assessment that includes the patient's subjective experience, functional limitations, and the impact of pain on their daily life. It also necessitates a thorough understanding of the patient's history of opioid use disorder, including current treatment status and any recent use. Utilizing non-opioid analgesics as first-line therapy and judiciously considering adjunctive therapies or low-dose opioids only when indicated and with careful monitoring, aligns with best practices. This approach is ethically sound, as it respects patient autonomy by addressing their pain, while also upholding the principle of non-maleficence by minimizing potential harm associated with opioid use. It adheres to guidelines from organizations like the American Society of Addiction Medicine, ASAM, and the American College of Emergency Physicians, ACEP, which advocate for multimodal pain management and careful consideration of patients with substance use disorders. Incorrect approaches analysis. One incorrect approach involves immediately administering high-dose opioids without a comprehensive assessment or consideration of non-opioid alternatives. This fails to acknowledge the patient's history of opioid use disorder, potentially leading to tolerance, dependence, and an increased risk of overdose or relapse, violating the principle of non-maleficence. It also disregards established guidelines for pain management in this population. Another incorrect approach is to withhold adequate pain management due to fear of addiction or diversion, leading to significant patient suffering. This is ethically unacceptable, as it violates the duty to relieve suffering and can be considered a form of patient neglect. It fails to recognize that patients with opioid use disorder still require effective pain management, and that appropriate strategies exist to address this. A third incorrect approach is to rely solely on subjective patient reports of pain without objective assessment or consideration of contributing factors, especially in a patient with a history of opioid use disorder where pain perception can be complex. While subjective pain is paramount, a comprehensive evaluation also considers functional status and potential non-pain-related factors that might influence reporting, ensuring a holistic approach. Professional reasoning. When faced with a patient requiring pain management, especially one with a history of opioid use disorder, the professional decision-making process should begin with a thorough and individualized assessment. This includes understanding the nature, intensity, and impact of the pain, as well as the patient's medical history, including substance use. The next step is to consider a multimodal pain management strategy, prioritizing non-pharmacological and non-opioid pharmacological interventions. If opioids are deemed necessary, their use should be judicious, at the lowest effective dose, for the shortest duration, and with close monitoring for efficacy and adverse effects, including signs of opioid use disorder exacerbation. Open communication with the patient about treatment goals and risks is crucial. Consultation with addiction specialists or primary care providers managing the patient's opioid use disorder should be considered when appropriate. Question 20. Operational review demonstrates a significant increase in patient volume presenting to the emergency department, with a notable proportion of these visits categorized as non-emergent or potentially manageable in an outpatient setting. This trend is leading to extended wait times for all patients and is straining departmental resources. Considering the role of emergency medicine within the broader healthcare system, which approach best addresses this challenge while upholding professional responsibilities? Option A. Prioritize patient care based on established medical acuity triage protocols, ensuring timely assessment and treatment of life or limb-threatening conditions, while simultaneously exploring strategies for optimizing the management of less acute presentations within the ED or through appropriate referrals. Option B. Focus on processing patients strictly in the order they arrive, ensuring that no patient waits longer than a predetermined maximum time, irrespective of their medical condition. Option C. Implement a strict policy of diverting all patients deemed non-emergent to their primary care physicians or urgent care centers immediately upon arrival, regardless of their ability to access these services. Option D. Establish a fixed time limit for all emergency department visits, requiring patients to be discharged or admitted within this timeframe to improve patient throughput. The correct answer is A. Prioritize patient care based on established medical acuity triage protocols, ensuring timely assessment and treatment of life or limb-threatening conditions, while simultaneously exploring strategies for optimizing the management of less acute presentations within the ED or through appropriate referrals. Explanation. Scenario analysis. This scenario presents a challenge in resource allocation and patient flow within an emergency department ED, highlighting the critical role of emergency medicine in managing acute healthcare needs. The increasing volume of non-emergent presentations strains ED resources, potentially impacting the care of critically ill patients and increasing wait times. This directly relates to the ED's function as a safety net and its responsibility to provide timely care for all patients, while also acknowledging the broader healthcare system's capacity. Correct approach analysis. Prioritizing patients based on medical acuity, as outlined by established triage protocols and guidelines such as those from the American College of Emergency Physicians, ACEP, represents best professional practice. This approach aligns with the core ethical and regulatory mandate of emergency medicine to provide immediate care to those with life or limb-threatening conditions. It ensures that the most vulnerable patients receive prompt attention, thereby minimizing morbidity and mortality. This is a fundamental principle of emergency medical services and is implicitly supported by regulations governing the provision of emergency care, which emphasize patient safety and appropriate resource utilization. Incorrect approaches analysis. Focusing solely on patient arrival order without considering medical urgency would violate the principle of medical necessity and could lead to delayed care for critically ill patients, potentially resulting in adverse outcomes. This approach fails to adhere to the fundamental ethical obligation to prioritize based on need, which is a cornerstone of emergency medicine practice and implicitly required by regulations focused on patient well-being. Diverting all non-emergent patients to primary care physicians immediately, regardless of their ability to access such care, could create access barriers and potentially lead to patients delaying necessary treatment or seeking care in less appropriate settings. Promoting appropriate utilization is important. A blanket diversion without considering patient circumstances or system capacity is not a responsible role for the ED and could violate principles of equitable access to care. Implementing a strict time limit for all ED visits, irrespective of diagnosis or complexity, would compromise the ability to provide thorough and appropriate care for all conditions. This rigid approach ignores the inherent variability in emergency presentations and could lead to premature discharge or inadequate treatment, directly contravening the ED's mandate to provide comprehensive emergency care. Professional reasoning. Emergency physicians must continuously assess patient acuity and system capacity. When faced with high volumes, the decision-making process should involve 1. Strict adherence to triage protocols to identify and prioritize the most critically ill. 2. Effective communication with hospital leadership and other departments to manage patient flow and bed availability. 3. Exploration of strategies to optimize ED efficiency for non-emergent cases, such as enhanced urgent care referrals or telemedicine options, while ensuring these do not compromise care for emergent patients. This balanced approach upholds the ED's role as a critical access point, while advocating for efficient and equitable healthcare delivery.